Next slide, please. So I am Stephanie Cabrera. I use she and her pronouns. I am in Vancouver, Washington, and I am a senior program manager with the Corporation for Supportive Housing. Eva, do you want to introduce yourself?
Good morning, everyone. Good afternoon to me. I am based in New York City. My name is Eva Lerner, and I am a senior program manager with the Corporation for Supportive Housing. Not, as I mentioned, based in Washington. I am part of a national team, so I'm here in New York, but I focus on health and housing partnerships, and am really excited to work with you all today on this budgeting and staffing training.
Great, thank you. So like I said, we're on session 4 of our Medicaid Academy, a 7-part series that we're working on. And so today, staffing and budgeting. Next week, we'll be talking about policies and procedures, and we'll be bringing in a quality expert, QA expert from CSH to talk all of that through with you. The following week, we'll be doing documentation and billing, and AmeriGroup will be joining us for that presentation, and we'll end with quality assurance and quality improvement. So we're about halfway, and we're happy that you've all stuck it out with us and excited to get the ball rolling today. Next slide, please. Right, so today we're going to be we'll be covering staffing models. We'll be going over some staffing models for supported housing and supported employment. We'll talk about how you estimate cost of care and your potential Medicaid revenue. And then we'll do a very quick review of our services budget tool, a time study tool, and a revenue projection tool. Yeah, so everybody's pretty much off camera. I want to encourage folks, if you want to stay off camera, to stay off camera. If you want to join, be on camera, whatever it is that's most comfortable for you. I know we have a lot of like camera fatigue or Zoom fatigue nowadays, so no pressure. And if you have questions, please pop them in the chat throughout. We will come off camera, or we'll pause the presentation throughout for questions, but please pop them in the chat throughout, and we'll answer them as we go. Next slide, please. And I'm gonna hand this over to Eva.
Hi, everyone. So today's very exciting training is all about staffing and budgeting, and critical to budgeting is cost versus revenue. This is probably very obvious, but I figured a helpful way to sort of kick things off is to just discuss the basics. So services budgeting 101, you've got your costs, and you would hope that the revenue you bring in is able to meet those costs, maybe even overshoot those costs and allow you guys to operate with a bit of a surplus. But what we're going to really discuss today is the various ins and outs of those costs, sort of key among them being the staff that you bring on your team. And we're not going to necessarily talk about specific revenue models. I think you guys all know your funders, but we are going to talk about how Medicaid can kind of play into that and expand upon the revenue that you're able to generate. We've linked here under key resources 2 tools that are going to be really, well, it's 1 tool and 1 guide that should be really helpful in this process. And that's the services budgeting tool that CSH has generated. And we'll be going over that in a bit more detail later on. But first and foremost, when it comes to costs, there's a variety of expenses you can expect to incur, chief among them being your personnel expenses. You also will have your operating expenses, also known as OTPS or other than personnel services. And this is obviously very basic. But if you're becoming a new supportive housing or supported employment provider, you may have some startup costs. And as you're looking to become Medicaid billing providers, you will also have some startup and ongoing Medicaid provider costs. And then, of course, when it comes to revenue, you are used to applying for grants. You may charge service fees or bill for private insurance. You might receive some in-kind benefits or partnerships from other organizations. And then Medicaid reimbursement being a new, very beneficial funding stream for you. So we shared this slide or a similar one in the Medicaid 101, but there's 4 sort of critical lenses that you can use to look at the costs you're likely going to incur. The ones that we're going to be really focusing on today are those programmatic costs. So that's the service provision, the staffing and supervision, the training you're going to provide your staff, But there's also a variety of other types of costs. You'll likely incur strategic costs, including the business partnerships that you might be developing, board governance that your board often will oversee and approve the costs that you plan to, will often approve the costs that you plan to incur. There's also logistical costs, so financial operations, the legal agreements, HR, IT, and then analytical costs, things like data management, quality improvement. All of these costs are included in the services budgeting tool that I mentioned we will be getting to later on. This tool is so helpful because it literally maps out every single cost that you're likely to incur and helps you understand what is your total cost of care and what amount of money do you need to bring in to actually support that. First and foremost, if you aren't sure where to begin in estimating the true cost of care, you'll want to start with your existing caseload sizes, because if you understand what your caseload sizes are, if you know the number of participants that you have in your program, you'll know how many staff you'll need to bring on. If you understand sort of the current salaries within your market, you'll be able to cost out the cost of those staff. And then you can start to think about your operating expenses. And once you understand sort of the basics, you can start to add additional startup costs to expand your program, the new Medicaid provider costs, and additional adjustments that you might make to your current costs in order to really achieve quality outcomes and really meet fidelity. So when we're thinking about staff, I think it's really crucial to think about the ecosystem that your team is operating within and that supportive ecosystem that really centers your participants. So here in the middle of this web, we have the participants. So either they're a supportive housing tenant or they're a supportive employment client, and their role is really to drive this work. They need to have choice and voice in the services they're receiving, choice and voice in their housing or the employment that they're going to take on, and work with you in the service planning process. You want to make sure that they have that choice in their housing type, in the neighborhood they live in their place of employment, and they, of course, will be the employer or the employee, and the leaseholder. And then there's the two sort of critical roles that your programs are going to play. That's the supported employment services and the supportive housing services. So who oversees supported employment services? The supportive employment supervisor, the employment specialist, the benefit counselor. And that role is really to provide the pre-employment services, the employment sustaining services, and the individualized benefit planning. Similarly, the supportive housing services team, who provides those services, the community support service provider. And they're responsible for the pre-tenancy support services, the tenancy sustaining services, and the individual service planning coordination with other providers. FCS only funds those two roles, right? They only fund the housing services, the tenancy and pre-tenancy, and the individual service planning, and it only funds the pre-employment services, the employment sustaining services, and the individualized benefit planning. And so other types of services that generally come into play in a supportive housing and in a supportive employment program, the other types of healthcare services they're going to receive, the benefits coordination, the mental health services, they're likely to be provided by other team members or even other non-funded, non-FCS funded team members or other organizations that you might partner with. So those types of roles include doctors, nurses, nurse practitioners, mental health professionals, substance use specialists, peer support specialists, community health workers, etc. And so they are also critical within this FCS, this supportive housing, supported employment ecosystem, but they won't necessarily be, or they won't at all be funded by FCS specifically. And then the final piece of that puzzle is that care coordination piece, which is often covered by the MCOs or health systems, medical homes, health homes, and they do that sort of medical care planning and utilization review. And so all of these different roles work together to support the client. But from an FCS standpoint, the only two roles that you can receive funding for are those supported employment and supportive housing services. So within the supportive housing ecosystem, CSH talks about 5 quality standards for ensuring the best outcomes for your supportive housing tenants. And these standards are that they need to be, all services need to be tenant-centered, accessible, coordinated, integrated, and sustainable. I'm not going to go into too much detail about this because this presentation is really focused on the budgeting component, but any supportive housing staffing model should incorporate CSH's quality standards, and that can really impact the way you design your staffing model and the case numbers that you include within your caseloads. So just from a high level standpoint, services should be tenant centered. They need to be voluntary, they need to be comprehensive, and they need to reflect diversity and the unique needs of the community that you're serving. They need to be accessible. Your staff needs to actively work to ensure that your tenants are aware of the available services, what services are accessible, and they need to be delivered in a culturally responsive, equity-focused manner. They also need to be coordinated. The primary service provider needs to establish connections to essential community-based resources. So again, when we look at that sort of broader ecosystem, this person is developing those relationships with other community providers that can help support the client or the tenant. They need to be integrated, so staff needs to support tenants in developing and strengthening the connections to their community. So you really want them to be grounded within their broader community, and that needs to be sustainable. The supportive housing project and the services funding should be sufficient to provide services to tenants in an ongoing basis. That's also really where FCS can come in, because it adds that additional layer of fiscal sustainability. So again, this was a very high level matrix, and I sort of brought the services piece to the front, or bolded that more, because that's really what we're talking about here. But we have linked to the CSH Supportive Housing Quality Standards Guidebook, as well as our quality toolkit for your use in your organizations. So within the supported employment realm, CSH doesn't have its own quality standards that it references, because we are a supportive housing organization. We don't focus on supported employment, but SAMHSA has produced its own evidence-based toolkits around supported employment, and it emphasizes a number of quality measures and metrics that you would want to make sure that you're incorporating. And I've highlighted sort of 3 bullets that I think are most important for from a budgeting standpoint. And that's 1, caseloads should be no more than 25, and really 20 is sort of seen as the gold standard on a fidelity matrix. 20 will get you the highest score. And services are provided within the community and should be assertive, which means sort of, as I'm sure you're already aware, outreach in the community, going out into the community and meeting, as opposed to meeting in your own office setting. And so these are important considerations when you're estimating A, caseloads, and B, productivity rates. For example, you can't bill for travel, and so you wouldn't be billing 100% of your employment specialist's time, because much of their time is not going to be billable. So we'll be getting into more details with that, but I just wanted to highlight some of these sort of high level points that are going to impact your budgeting framework. And we also here have linked to one of the evidence-based toolkits on the SAMHSA website that's specifically around training your frontline staff. So that all comes to how to estimate your caseload sizes. So I think we've sort of alluded to a number of these questions, but first and foremost, who are you serving? Because the population you serve is likely going to have different needs and will impact the number or the caseload sizes that your staff will be able to deliver those quality services to. What is the best practice service model that addresses the needs of your client populations? Different service models are going to have different caseload sizes. We here are going to be focusing on tenancy sustaining or tenancy support services. That's really what FCS funds. FCS isn't, it doesn't fund an ACT model. There are other funding streams for things like ACT or intensive case management. So within this context, we're really talking about the tenancy or housing supportive services, but different models like I'm mentioning are going to have different caseload recommendations, and that's going to impact your budget. Are your individuals new to supportive housing or supported employment? Folks who are newer to these programs will likely require a bit more time, and that could reduce your caseload sizes. Are case managers new to supportive housing or supported employment? That will impact the level of onboarding required and training required. Again, could decrease your caseload sizes, could decrease your billable productivity. And is supportive housing project-based or scattered site? Again, that goes to the travel times that will come up and the amount of service that your case managers are able to provide. Project-based, you probably can have a higher caseload than in a scattered site model. So we here are providing some best practice caseload numbers and service provision time estimates for your use. On the left side, we have included a number of the key populations that you're likely to encounter. Individuals, families, dual diagnosis, folks with intellectual developmental disabilities, older adults, transition age youth, and the caseloads associated with them either living in scattered site or single site. And you'll see there's a little bit different. Single site, you can likely work with a higher number of folks than in a scattered site model. We also have linked here to the services budgeting tool where these numbers are pulled from. In the supported employment side, we actually pulled from the IPS, the IPS Center's supported employment fidelity scale, IPS Center being the individual placement services, which is sort of a foundational model of supported employment, as I'm sure you're all aware of, and their fidelity scale. And as you can see, you get the lowest score if your employment specialists are working with 41 clients or more. It's really recommended that they work with 20 or fewer, 25 sort of towards the max. And where it says here, service provision 96% of the time. Again, this really comes down to the fact that employment specialists are expected to only provide employment-related services. They're not supposed to provide any of the other types of supportive services that folks who are benefiting from supported employment would require. They don't provide the mental health services. They don't provide other types of case management. They're supposed to provide employment services 100% of the time. That said, as we mentioned before, various types of services that relate to employment are not billable. So they're not going to be able to bill 100% of their time. So it's important to think about that. Some ongoing costs to consider. So as I mentioned, from a programmatic standpoint, there are not only personnel services, but there are other types of costs that are likely going to come into play. So there is the services staff, but there's also the training and supervision. From a training standpoint, you might need to bring in external trainers. That could have a cost. You might have to pay for trainings or pay for conferences. You also aren't able to bill while your staff are in training, so that's foregone revenue. And from a supervision standpoint, supervision time is time that is not worked with clients. It is time that you're not able to bill for, so that comes with a cost. From a business support standpoint, if you are a new provider, you might be bringing in business consultants to help your program start up. There are a number of Medicaid specializing business consultants that we can talk about in a few slides that cost additional money. There is also transportation costs, especially if you're working in an assertive manner or in a scattered site model. Not only are there costs affiliated with transportation, there's gas and there's mileage, but you also cannot bill for that time. And then there's quality improvement, costs affiliated with paying for your QI staff time that's devoted to fidelity audits or performance improvement, data collection and analysis, and the IT and data plans. So the costs affiliated with ongoing electronic health record licenses or HMIS licenses, costs of phone, cost of internet, cost for IT staff. So these are all additional costs that also are not billable. And I see in the chat, we have a question, does the caseload size account for inactive participants that are authorized for services but have no engagement? That's a really good question. And these caseload sizes are really about actively engaged participants, but it's more of an average. And so it doesn't necessarily include specifically inactive participants, but I would say this is really more factoring in participants that you're actively working with. So we talked about ongoing personnel, ongoing operational costs, but there's also the new costs that are likely that you're likely going to incur if you're starting a new program or if you are a new Medicaid provider. So from a general startup cost, those sort of one-time costs you only need to factor in the beginning, hiring new personnel costs like background checks, new staff training, person-centered design, for example, hiring or bringing on a focus group of people with lived expertise who can provide guidance on how they would like to see their program run. And one thing that CSH really likes to encourage is reimbursing people with lived expertise for their time. Operating expenses, you're going to need to buy furniture and equipment and stock with telecommunications. So there's the new operating expenses that are going to come into play. And then some of the hardware and software you're likely going to need to bring on, computers, tablets, bringing on a new electronic health record, signing up for an HMIS. So those are going to be some of like the initial sort of startup costs where you're going to require an influx of money. And as Rayanne, the program manager for FCS supportive housing, has shared, the FCS team does have a number of grants that they can provide for new startup costs. And then there's some ongoing new Medicaid provider costs. For example, Medicaid requires that you have a quality improvement manager. They also require a compliance officer. You may want to bring on a Medicaid and or billing support consultant, and that can come with its own costs. Often around 5 to 8% of your monthly claims will go to that consultant. And then you'll need to provide annual HIPAA and compliance trainings, which is another Medicaid requirement. You'll also have some ongoing operating expenses with being a new Medicaid provider. For example, you'll be required to maintain liability insurance, and you'll be required to have some locked filing cabinets. Locked filing cabinets, not an ongoing expense. You only need to buy those once. And then from the hardware and software standpoint, if you're going to be billing, you might want to purchase some billing software, and you will be required to have email and data encryption. And I see we have another question in the chat. Where does billing staff and record keeping fall under the ongoing costs? So if I understand your question correctly, where do you account for the staff that are billing? That would be under personnel. And record keeping, the active keeping records could, if it's electronic records, would potentially fall under an EHR license cost, or if it's paper records, would fall under that one-time like locked filing cabinet that you need to provide or that you need to purchase as a new Medicaid provider. But the time of record keeping would be non-billable. You have to provide your case, you have to keep your case notes, of course, and that would not be billable, but it would be under staff time. So again, any staff time would fall under that personnel cost. So as I mentioned, you can't bill for 100% of staff time because there is time that is not billable. So you'll want to think about when you're estimating your total cost of care, how much of that time is actually billable, what that productivity standard is. And that really will play into the model of reimbursement that the program is going to be operating within. So supported employment operates in a fee for service model of 15-minute increments, and supportive housing is per diem. And so that will play into sort of how you conceptualize the way you're able to map out your staff's time and then bill. A few other pieces that are going to play into estimating productivity standards includes time off. Your staff are going to be taking paid leave, sick time, FMLA, bereavement, vacation. Time that they're going to need to conduct administrative tasks. Again, administrative tasks are non-billable. Other non-billable services like outreach, lunch breaks, they're not going to be billing for the time that they're eating lunch. Travel time, especially if for scattered site participants, you can't bill for that travel time. Your new hire ramp up and onboarding, all of those trainings, all of that is going to reduce the productivity from a billing standpoint that your employees, that your billable staff are able to work. And then you'll also want to create a buffer for your authorizations, for your rejected claims, for your quality insurance. So you'll want to imagine that those other types of tasks that are going to come into play are also going to reduce the amount of time that you can estimate your staff will be billing for. So one helpful technique for estimating productivity is to actually create a billable time study for your staff. And what this helps you to answer are how many days per month or units of service each participant will receive billable services. One thing to note is that FCS does not allow more than 30 days for supportive housing or 120 units for supportive employment over a 180-day period. And so when you're thinking about your caseloads, the number of staff you'll need, and you're wanting to use your caseloads as a way of predicting your revenue, you have to keep in mind that you can't see one client more than 30 days in a 180-day period. It says here, without an exception to rule, you can get an exception to rule, which means that you'd have to submit a request to AmeriGroup to allow you to bill over 30 days for supportive housing or 120 units for supportive employment. But from a basic high level perspective, when you're using this to estimate your the caseloads that you're going to want to bring on, it's helpful to not overestimate the amount that you can see your clients. You'll also, again, you'll want to think about not only how much service you're able to provide each client, but how many clients per day each billing staff member plans to see, because again, that's going to impact the revenue you can bring in. And ultimately, what revenue will this generate for your agency? And one suggestion is that you should set service targets based on your participant needs and calculate your revenue projections from there, because ultimately we want this to be client-centered. It shouldn't be about generating revenue. So you'll want to make sure you determine how, what the quality minimum standard service is to deliver within, of course, that sort of time construct that FCS puts out there with the 30 days versus 120, and then make your revenue projections from there. And again, it's important to keep in mind that these are all going to differ with scattered site versus single site and rural versus urban. Travel time really impacts the amount that you can bill for. Here on the left, I have provided a little table that sort of mirrors what a time study could look like. So we have here time with Molly Moo discussing where she wants to live. That's from 9 a.m. to 9:45 a.m. Total minutes was 45. Is this a billable service? Yes. This is an active engagement with a supportive housing tenant. This is a pre-tenancy support. And here in the final column, we have units of service. The unit of service would be 1 because, as I mentioned, supportive housing is a per diem reimbursement model, which means that you bill per client seen per day. So it would be 1 unit of service at $112. Then we have here a staff meeting from 10 to 11. Is this a billable service? No. Units of service, 0. Travel time from 11 to 11:30. Billable service? No. Units of service? 0. Then meet with Jerry Jets to discuss the issue with a neighbor he had over the weekend. 11:30 to 12. Units of service? 1. Again, because it's a per diem reimbursement model, so 1 at $112 per diem. And then finally going down, you most likely are not going to have, you're not going to do a time study for both supportive housing and supported employment. These are 2 different programs, 2 different organizations. However, I wanted to show you what it would look like if you were conducting a time study for both. And so I just blended them into one. So bear with me there. And I just italicized the supportive employment example. Meet with Jessica Rabbit to discuss employment goals for 45 minutes. This is a billable service. The units of service is 3 at 27. And that's because, again, supported employment is a fee for service at 15-minute increments. And so every 15 minutes is worth $27. It was a 45-minute service provided. So that's 3 units of service at $27. And this here is just quickly to show you the foundational community supports reimbursement rates. Again, it's sort of pulling what we already shared in the time study, but making it very clear. The supported employment benefit is, again, 1 unit equals 15 minutes of service, and you're limited to 120 units or approximately 30 hours in a 6-month authorization period. You can apply for an exception to rule if you require, or if your service participant requires additional services within that time period. And the reimbursement rate is $27 per unit of service. The supportive housing benefit is at a per diem rate. So again, that's per client per day. And that is a limit of 30 days of service per 6-month authorization period. And that's at a reimbursement rate of $112 per day. And you can apply for an exception to rule if your client requires additional services within a 6-month period. So the CSH services budget tool, I gave you a big overview of all these different components, but what I really want to talk about is the services budget tool because it brings all of this together in one place. So what does this tool do? Well, it supports providers to estimate the comprehensive costs and potential revenues for supportive housing and supported employment services. Big caveat here, I have here, it says supportive housing and supported employment. Right now, this tool that we've linked to is only for supportive housing. Stephanie and I are actively working to adapt the tool to a supportive employment context, and we'll share it with you when it's ready. But for now, it really is only useful for supportive housing. Don't expect it to change that vastly for supported employment, but the pre-populated numbers and formulas are really specific to supportive housing. So what the tool includes is it allows you to compare the cost and revenue projections across a variety of service models. It allows you to share the number of, it shares the number of staff recommended for your service model, and it calculates expected costs based on program-specific inputs that you provide. And it calculates potential Medicaid revenue based on specific reimbursement models, rates, and units of service. And linked here is that services tool and user guide. And I said that I was going to talk about how Medicaid could help support your revenue. So I'm going to click here and see if it actually shares let's see if I'm able to share my screen and you can actually see the tool.
Somewhere. Yeah, health and housing services. We might have to do a little bit of homework.
Can you all see the tool? Beautiful. Okay, so all right, so this is the servicing budgeting tool. It has a number of tabs. I am going to start by going to the basic input and assumptions. And what this does is it allows you to set basic foundational info that you will use as you use this tool. So first and foremost, we want to start with the basic inputs. So is this a new supportive housing program? Let's say that it is. So you'll select
Eva?
yes. Yes,
Sorry to interrupt. Can you zoom in just a little bit?
absolutely.
Perfect. Thank you.
How is that?
That's good.
Okay. So is this a new supportive housing project or program? This will impact your caseload sizes. Let's say it is, we'll keep it at yes. Do you want to include general startup costs in your budget summary? Let's say yes. Do you want to include Medicaid provider costs in your budget summary? Let's say yes. And then it links to those two tabs. And then here it allows you to determine which service and staffing models you want to include in your budgets. I'm going to put no for the non-FCS models. So right now we're really only focused on FCS. But yes for foundational community supports, and it links to that staffing model tab. And if you want to learn more, you can click any of these links to learn more about the various service models. And then underneath, it allows you to input basic budget assumptions that are going to be used in your service model. So administrative indirect cost rates. So whatever your approved indirect costs are, you can add that here. Transportation to scattered sites. Transportation costs are necessary budget component for scattered site. For agency unsure of miles traveled per month, CSH recommends budgeting 20 miles per day. So we have here just basic 20. Site-based mileage. Site-based mileage varies greatly depending on the breadth of the service coordination and transportation offered. CSH recommends up to 5 miles per day for site-based transportation. So we have here 5. Then mileage rates, the 2023 federal mileage rate for reimbursement is 0.635. So we have here 0.635. Then you can set what you expect the annual inflation to be so that you can budget out costs and revenue over a number of years. And then the amount that you're likely to spend for training and professional development, staff training, professional development, and appreciation costs are recommended to be between 1 and 3% of your wages. So we just averaged it to 1.5. And then fringe. Fringe is often around between 30 and 40%. We just have 32% here. But because these cells are all light blue, you can add your numbers. So there is a guide that goes with this tool and it explains how the tool is color coded, but for your reference, light blue cells mean you can add your own numbers. And then underneath are caseload assumptions that are used. These are the caseload assumptions that we pulled into the slide deck. So from a best practice standpoint, we have provided you with the numbers that we think you want to stick to from a caseload standpoint, but you can change these caseload expectations and they will update in your model. And then you'll want to put a supervisor to supervisee ratio. We recommend 1 to 8. And then there's a number of program assumptions to review. So I am going to click on this link to FCS staffing model so that we can go to FCS, and I will zoom in. So it starts here by allowing you to select the populations you plan on serving. And then it pulls in the recommended caseloads associated with the staff or with the tenants that you will be working with. And then you can put how many tenants are in either a scattered site building you're working with or in a single site unit building you're working with. And again, the corresponding recommended caseloads. Underneath, you will complete information about your billing staff. So how many community support service providers? Over here, it tells you based on the number of tenants, the recommended number of community support service providers. Right here, you can change this number. It is a peach cell, which means there is a formula that calculates the recommended number, but the formula is not locked in the tool and you are welcome to change it. And then you would add your salary that you pay your community support service providers. It also is divided by billing and non-billing staff. So here are your billable staff, and then underneath you would add your non-billing staff as well. And then it shows you your total staff. Here is where Medicaid comes in. So this brings in a number of the concepts that we talked about in the slides, starting with how many days, how many units of service are your staff going to be working? So basic estimates, assumptions that they're going to work 40 hours a week. They're probably going to take 10 federal holidays. Again, these are all blue, so you can change those numbers. How many days of PTO you plan on offering your staff, how many personal days you'll be giving them, any other days they might take off. And then it calculates the total days per year that your staff will likely be working based on all of these numbers. And then underneath, you can set the Medicaid specific billing information. FCS is a per diem program. Now, supported employment is 15-minute increments, but this is really built specifically for supportive housing. So per diem, we know that the per diem rate is 112, so you would put that there. And then you would provide your estimated productivity standard, which we talked about in that time study you would use to estimate productivity. Here, we're just estimating that they'll probably bill around 75%. And then it automatically calculates the annual units of service. Again, per diem is a per day reimbursement model, so per client per day. So that's 226. And then again, the time study is really critical for understanding and estimating how many clients you will see per day. Because in order to predict what your revenue is, you're going to need to know how many clients you'll be able to bill for per day. So based on the info that you add here, it will automatically generate your estimated Medicaid revenue down in this cell at the bottom. And it will show you, based on your program costs, what % of your program costs Medicaid revenue can cover. So right now, based on the program costs listed above, you can cover 81% of your program costs with FCS revenue. Program costs are all added in here. And so based on the numbers you include in your wages and your salaries, this is your wages and salaries are calculated, your employee benefits are calculated. Then if you bring on other contract personnel, other personnel services, expenses, you can add those in blue, and then it totals. And then you can add other operating expenses. As we talked about, other ongoing types of expenses you can expect to find are things like rent, utilities, billing insurance, IT, vehicles. So all of those various other than personnel operating expenses are included here in operating expenses. And then it totals it. And then here you've got your revenue. You can add in your in-kind revenue, your program service fees, your grants, and it will show you your total revenue. And at the bottom, it'll show you your net. So right now, I don't have anything under revenue except for Medicaid, and your total program costs are $941,000. So you're in the red of about $182,000. Again, most of this is not filled out. But it'll show you for 1 year's worth what your general 1 year's worth of expenses and revenue will look like. You also mentioned in basic inputs and assumptions that you wanted to include general startup costs and Medicaid provider costs. So you go to the general startup cost tab, and you can add any general startup costs that you expect to find. Again, many or the big buckets that we included in the slide deck under startup costs are broken down here and what sort of the standard startup costs are. And then here we've got your Medicaid provider costs. And again, I'm not going to go into great detail about how to use this table, but I have here that we're only applying it to FCS tab 6 because we're only talking about FCS. And it shows you all of the costs associated or generally associated with being a Medicaid provider, whether they're a required cost, how frequently those costs are going to be incurred, what those costs likely are, how many units, if you want to include it in the budget, and the total. So these two tables, these two tabs, then get pulled into your overall multi-year budget. We have a column here for Medicaid costs, a column here for startup costs, and it all gets pulled into your 1 year. And then your 2 year is that with inflation minus any startup costs, because again, you only need to pay startup costs once. And then your year 3 is year 2 with inflation. So what you would likely expect to find is that your costs will go down slightly from year 1 to year 2 because you're not going to have any startup costs. And then they will go up slightly from year 2 to year 3 because of inflation. And then you'll have your total 3-year budget and what the net is. And that is a very, very, very quick rundown of how the tool works. Finally, I just want to draw your attention to some summary tabs. If you were wanting to model out different service models, you can compare them across this budget summary output. Because we selected no to the other service models, we can only see FCS. But if, say, we had selected yes to ACT now shows up. And then it shows you again your net. So you've got your basic summary outputs for your services costs from your inputs and the revenue. And then if you wanted to compare annual total budget costs and revenue across different models, just for 1 year, you can use the annual total budget summary. So I am going to stop sharing the budget tool and return to the slide deck. Bear with me. Can you see the slide deck again? Perfect. Okay. There's also a user guide, as I mentioned, which explains and walks you through the tool in much more detail than I just did. There is also a simple budget forecasting tool. This is a much simpler tool, and it is for both supportive housing and supported employment. What it does is it forecasts your revenue. So it allows you to see, let's start with supportive housing. For a community support service provider, the number of days they plan to work per week, average number of clients seen per day, what they are billing at, which is 112, and then the total weekly revenue, total monthly revenue, and then your total annual revenue. And with supported employment, same idea. You've got your supported employment IPS provider, percent of time that is likely to be billable, number of hours worked per week, number of units per week, the rate of those units, total annual revenue, and total monthly revenue. So again, a much simpler tool, but it really is a very basic revenue projection. All right, so there are going to be a few external impacts that will affect your projections. So for one, slow or inconsistent referrals to you as a provider. If you're not receiving constant referrals, you're not going to have, actively engaged caseloads, and you might see your revenue dip. Again, because if this is all based on clients as opposed to grants, then you need to have more actively engaged clients in order to bring in more revenue. Member authorization for services lapses. Okay, so again, this goes back to what we talked about before in a previous slide or a previous presentation about being eligible versus being enrolled. Just because someone might be eligible for Medicaid services does not mean that they're authorized to receive them. And if they are not authorized and you're providing those services anyway, they are not going to be able to be reimbursed for those services. Apple Health enrollment lapses. Again, just because someone may be eligible for Apple Health or Medicaid, as you remember, does not necessarily mean that they are enrolled in Medicaid. And as we all know, the Biden administration has ended the federal emergency from COVID, which means that the moratorium on Medicaid authorization is expiring. I believe May 11th is the official day that everything, don't quote me on that, I might be wrong, but I think May 11th is the day that the federal emergency is up, which means that Medicaid members are going to start being required to reauthorize to be enrolled in Medicaid. So this is really important that you guys stay on top of whether or not your participants are enrolled in Medicaid, because you will want to make sure they are in order to continue to have them be authorized for FCS. Claim denials. This is an unfortunate reality. Medicaid is complicated. We are here to try and make the process easier for you, but you very well may encounter times when you submit claims and AmeriGroup denies them. That will slow things down because you'll want to resubmit claims in order to be reimbursed. So again, that is non-billable time that you're going to be using to engage in administrative tasks. And of course, if you're expecting that revenue to come in and the claim is denied, again, that just slows everything down. Rates not keeping pace with inflation. Inflation has been quite extreme lately, and rates aren't always, they don't always keep pace. So it's one thing to keep in mind that you'll likely see costs going up over time, and you may not necessarily see that revenue potential increasing with it. And then potential for reimbursement delays for whatever reason. Right now, I'm not thinking of any reasons why there could be reimbursement delays off the top of my head, but they do happen. And that brings us to the end of this training. It was a lot of information that was thrown at you in a very short period of time. So I'm gonna, in a minute, stop sharing my screen so that I can be available for questions. But I wanted to share some useful tools with you that we used in this presentation or that we referenced. So for starters, the CSH Supportive Housing Services Budget Tool for FCS. We also have the user guide that goes along with it, as well as those the simple budget forecasting tool. Again, much simpler, but less comprehensive. We also are including a staff time study template and the fidelity scale for supported employment. And then some guidance documents that are available. So we've included the AmeriGroup provider manual, as well as their website, the Washington Healthcare Authority's provider website. These were also shared in previous slides, or previous presentations, but I think it's always worth sharing again because they are the source of truth for this program. We are sharing the FCS reimbursement rates, which are also included in this presentation. We're also including the CSH quality standards for supportive housing and the guidance document for that. Again, that's not specific to a budgeting framework, but it is specific to ensuring that you're providing high quality services from a supportive housing perspective. And in a supply demand economy, the better the quality, you're likely going to have the quantity that you're able to serve go down a little bit. So it's really important that you keep those in mind. We also have the CSH Supportive Housing Quality Toolkit that's linked. So that is the accompanying toolkit that goes with the Supportive Housing Quality Standards Guidance document. And then we're providing the SAMHSA Supported Employment Evidence-Based Toolkit training for staff. And then FCS completed a time study analysis for supportive housing and supported employment. And we think that that's really useful as you're thinking about how much time to allot to your various billing components that your staff are going to be engaging in. So I am going to stop sharing my screen and open this up for questions.
Very quickly, while people maybe are mulling it over and thinking of their questions, I popped in the chat the link to our extranet that has all of the copies of the slides from previous sessions, recordings, and then most of the link documents in there. So the link is in there, the password is there. Feel free to peruse, and everything, all of the links in the PowerPoint slides that are in there are also live. So if there's anything that we didn't link document wise, you can click on it in the slide as well.
And Stephanie, very quickly, when you shared the extranet, did you make sure to mark it as link is available to everybody, or did you not? If you didn't select that, they won't be able to use that link.
Can somebody go in and tell me if I did it right? I think that
you
yes,
can access
okay.
it.
Yeah,
it's working.
Thanks,
that
Dirk. Awesome. Okay, good. Perfect. So one other thing I want to mention is Stephanie and I are available for some technical assistance around the services budgeting tool. I would not call this, hour-long training a technical assistance around the service budgeting tool. It is a complicated tool, and quickly showing you on a very quick webinar how to use it is not comprehensive. So if you are interested in learning how to use this tool in more detail and potentially incorporating it into your operations, we have included in our aftermath survey that I'm going to be putting on the screen a question asking if you're interested in receiving TA and for your email, and we can schedule some of those. We can schedule some time to do that. So I just want to put that out there, that is available to you if you are interested. Well, I will go ahead and reshare my screen to get to that page since I'm not seeing immediate questions. And here is the survey. So I would very much encourage you all to complete this feedback survey. Again, it is really, really helpful for Stephanie and me to make sure that we are providing you with the content and the method of delivering that content that is useful to you. Next week, we will be going over policies and procedures. There is a QR code to register for that if you are not, if you have not registered already. And I see we might have a question in the chat. Oh, Stephanie, Stephanie shared the link. So I'm going to leave this screen up, but feel free to hop off if you have completed the survey. I don't want to take up any more of your time. Thank you guys so much for joining us today. I hope it was helpful. If it was not helpful, please be honest in the feedback survey so that we can improve. Really grateful for all of your time, and we look forward to seeing you next week.
Thank you, everyone.
Hey, I have a question for Eva.
Yes, of course.
So I think, hold on, let me check the date. I sent our paperwork, our first round, to Matt Christie on May 3rd.
Mhm.
And I haven't heard anything back yet from him. I even sent like a reminder email. Is he still around there?
Matt Christie is definitely still around, and you said you sent your enrollment paperwork, the initial
May
enrollment.
3rd?
I think it can take somewhere from like 2 to 5 weeks.
Oh, okay. All right. Well, I just didn't
Yeah.
want to, I wanted to make sure that, I got them to the right place and
Yeah,
that.
absolutely. Matt was
Okay.
definitely the person to deliver it to. But if you haven't heard yet, it's only because it can take a little bit of time.
It can
to
take some
process.
time.
Yeah,
Got it. All right. Thank you for that.
no problem.
Ava and Mike. Mike, what's your agency? And I'll make sure to follow up with Matt just to make sure we're not missing any pieces or anything.
No, I don't want to be super persistent if that's the time frame, but I'm with Anything Helps.
Okay. Yeah, no worries at all. It's not too much at all. We check in every week just to see where folks are at or if
Oh, great.
in the process. So I'll follow up and let you know.
I really appreciate it. Thank you.